Hi, my name is Madeline Marenthaler, and I did my presentation about lumbar herniated discs. So, the chief complaint of this patient is that he has been having back pain. He's been having lower back pain that is radiating down his left leg for 3 weeks. So, history of present illness. A 45-year-old male presents to the office complaining of low back pain that radiates down his left leg that has been present for 3 weeks. According to the patient, the pain began after lifting a very heavy box at work. He describes the pain as sharp and shooting, starting in his lower back and going down the posterior of his left thigh to his calf. He rates the pain as a 7 out of 10. The pain becomes worse when sitting for long periods and bending forward, and he gets relief while lying flat on his back. Ibuprofen has provided him with minimal improvement. He reports that he has had associated numbness and tingling in his left foot, but no weakness, bladder or bowel incontinence, fever, recent trauma, or weight loss. He denies having previous back pain. His past medical history is significant for intermittent low back pain, but no prior surgeries or injections. So, for our discussion question, which additional findings strongly support a diagnosis of a lumbar herniated disc rather than just a muscular strain? The first option is lower back pain that improves with activity. The second is radicular pain that radiates down the leg. The third option is pain in the lumbar region with no radiation. And the fourth is tight muscles along the lower back that are painful when pressed upon. And the correct answer for this is radicular pain radiating down the leg. And we'll explore more into this now. So, the physical exam findings. The patient was positive for a straight leg raise test. The patient, a straight leg test is when the patient lies on their back and the provider lifts one leg. The patient had sharp shooting pain down their left leg, so that test is positive. There was decreased sensation in the L5 dermatome. A dermatome is an area of skin from a specific spinal nerve. There is decreasing sensation in the L5 dermatome, which is the outer leg and top of the foot. So there's two kinds of imaging that we usually do with back pain. The first one is an X-ray. This is where you can see the bones, tissues, and organs, and they're great for fractures and bone spurs, but we can't see a disc on these. So that our second option is an MRI. This is where we can see detailed images of discs, nerve roots, and spinal cords. And this is a visual confirmation of a disc hitting a nerve, so preferably the type of imaging that we would like to use. This is what the patient's MRI looked like. This patient's side view MRI confirms that there is a disc herniation at the L5-S1 level. The white arrows point at how the L5-S1 disc is being pushed into the spinal canal, and this is right here. The dark spinal canal has white, which is the spinal fluid, and then all along here is the white spinal fluid, and gray, which is the nerve roots. As you can see, some of the gray is here, it goes down here. Since the disc is pushing into the spinal canal, it is also pushing into the nerve roots, which is causing the back, but also the leg pain. So the final diagnosis that we have for this patient is that the patient has a lumbar herniated disc at the L5-S1 level. Another name for this is a lumbar disc disease, a slip disc, a ruptured disc, or a bulging disc. Definitions and symptoms. The definition of a lumbar herniated disc is some of the nucleus from the spinal disc pushes out through a tear in the annulus. Common symptoms is leg pain, which is often felt in the buttock, thigh, and calf. There's numbness or tingling, and this is from the nerves being pushed on. There's also weakness in the legs, which can cause people to stumble. Risk factors. So our first risk factor is weight. Excess body weight can put more pressure and extra stress on discs in the lower back. Genetics. People may inherit a predisposition to developing a herniated disc. Being sedentary, regular exercise can prevent a herniated disc. Smoking. Smoking can actually reduce the oxygen supply to your discs, which causes them to break down faster. Your occupation. More demanding jobs that require heavy lifting, pulling, and bending sideways can also increase your risk. So there's two treatment options that people will usually choose. Usually they first start with a conservative one as it's not the invasive option. So conservative can look like rest and lessen activity, medicine, for example, ibuprofen and naproxen, physical therapy, heat or ice therapy, oral muscle relaxants, and also chiropractor as well. So for invasive, there's a few options. So the first one is injection, specifically epidural steroid. This reduces the inflammation and swelling around the compressed nerve. And then our second option is a microdiscectomy, and this is a kind of surgery. This is when a surgeon removes a portion of the disc that is pressing on the nerve to relieve the pain. And then there's an artificial disc surgery. The damaged disc is replaced with a fully new artificial disc. And one interesting thing that I learned was, do herniated discs heal on their own? So, in short response, yes, they can, but it's not always. So, the symptoms can initially be very severe and painful, but these symptoms do not always last a long time. Many people who develop a herniated disc have no symptoms 6 weeks later with no medical treatment. Generally, it is believed if the herniated material is smaller in size, it is more likely to revolve itself. But this is not always the case, as patients will come in usually after the 6 week mark if their pain is still persisting, and they can start with conservative options first and then dive in to the invasive options. And then here are the sources that I use for this presentation. Thank you so much.